So, welcome to pediatric nursing. You know, for you all to be in pediatric nursing, you've done a lot of work to get here, and you all should be congratulated on that. You know, pediatric nursing is like a med surge too. And I'll warn you right now, it's not easy, but I will make it as easy as I possibly can. I give you all the tools that you need. You just have to use them. And if you've ever had a student before who's already had me, they'll tell you exactly the same thing. I'll give you your PowerPoints and I update them all the time to make sure information is either on your exams, your HESI, or your NCLEX or quizzes. I mean, this is all stuff that'll be there for you. So if you look over the PowerPoints and then test yourself on the Kahoots. Now, these Kahoot questions I make myself. I look at a concept and I'm like, well, what could that concept be covering? And how do I want you to think? And sometimes it's one question on the concept, and sometimes it's more than one to try to have you wrap your minds around them. Because at this point of learning, you're not going to be memorizing things anymore. You're going to understand what something means and apply it to a condition, or through an assessment, you can figure things out. And as I do the Kahoots, I'm going to try to teach you that, okay? Now, I always give the Kahoots after I post the recording. It'll be in two places. When I post the recording, I think you all know I have a YouTube channel. It's Professor Bogart Pediatric Nursing. I've got 2 years of stuff on there. You can go back and listen to last semester's or the one before that information. And they're similar, not quite the same, because I don't teach the same all the time, but very similar. And you can go back and look at that if you're having a trouble with an area, okay? The Kahoots will be on that YouTube channel as part of the text, and I will put the recording and the Kahoots and the PowerPoint again on an announcement for you. So I try to keep you organized. So you're going to see 2 weekly, for sure, posts for me on the announcement page. I don't put 100 announcements every week. I'm not one of those, because after a while, you're not going to read them. And I know that. It's like, oh, another one? Really? No. You're going to have one, week 1 information. And then the next one will be after I get the recording. It'll be week 1 recordings. Okay? When you get your exam reviews, it will be all the Kahoots, all the everything you need to go and study into one place. When I do the recordings that come in, I have one announcement. I just keep editing. So in one announcement, you'll see the 7 of us doing the recordings instead of 7 different announcements. I try to help you because many of you are in 3 courses. So that's some of my promises to you. I've been at Fortis for a long time now. I think I'm called an old timer now, since 2017. And actually, I came to Cutler Bay in 2017 and they needed a pediatric teacher. I said, yeah, definitely, I could teach pediatrics. I've been at Nicholas Children's Hospital, this huge pediatric hospital here, since 1994. So up to 2017. So pediatrics is really good. Now, before that, I did a lot of adults. And that is actually going to help me teach you differences between children and the adults. And that will help you if you are in your med surg classes too. So that will be a helpful thing for you. I also was asked to teach pharmacology. And I went, pharmacology? And I went, okay, I guess I can fake it. Well, oh my goodness, pharmacology was rough, but I learned it. I learned it well, and I taught it, and I totally made it understandable. I also developed a dosage calculation method that it simplifies this ratio proportion analysis. I don't even understand what that is, because you're adding things and subtracting things, and that's all you're going to do is get errors. You put something down, you just change to make sure they're all in the same format, micrograms, milligrams, whatever, and you just multiply and divide. And that's the way it works, up to mics per kilo per minute. Now, one of these classes if you want at the end, and if we have time, I will go over it a little bit with you to try to tell you how to think. And even if you do a different type, it'll show you how to pull out those important numbers that you need to use in order to be able to figure out these problems, okay? So let's go ahead and start. Any questions so far? All right, let's go ahead and let's go ahead with, of course, we have to do the PowerPoint about what's going on, what is expected from you, and you know what I'm going to do for you. I mean, you already know that I'm going to be here. If you need anything, you just need to ask, send me a message, or you're going to send me something on my cell phone, and we'll get to that. So online learning is different because you're usually all at home. So there's a lot of distractions around there. So try to be in a place that is with the least distractions. And I know sometimes that's really difficult, especially with you with young children or et cetera, et cetera. With online learning, I'm going to tell you every week what's due. I'm going to give you reminders, usually on the weekend, either Saturday or Sunday before it's due. Hey, don't forget this project. Don't forget this assignment, to try to help you to remember. Because some of you with the 3 courses, it's going to get all confusing. Now, I am the lead pediatric professor. So, you're going to first, talk to me and then talk to me again, which is the lead. And then if there's any problem, something that you're not understanding, something that you need immediate response, I'm not giving you what you want, please go to my boss. I will not be offended. I will not take it out on you or any of that suchness. Please, Darlene Brown is there to help. She is an open door, and you can call her and send messages, and she gets back responses almost as quick as I do, which is quite amazing. Consider she is over all of the online programs, all of the specialties, and there are a lot. Remember, it's PN and RN and all the courses. So she's there. Please, this is her number. I would write it down. I would put it in your phones right now. 720-665-6101, and look at her email, because D Brown won't get to her. You must write Darlene.Brown. Okay? Apparently there's another D Brown in the Fortis system. So let's say something's going on. You can't get to class. You can't get an assignment done for whatever reason. First of all, let me know. I want you to, before something is due, I want you to send me a message. Tell me what's going on. Text me. If it's like urgent, I want you to go ahead and I want you to call me if you need to, okay? I'm always available. Now, if there's anything that you're seeing in there, whatever, if you don't talk to me before they're due, I really can't do much for you. So again, when do you contact me? Before something is due, before a class. I am here to understand. I'm a person. I understand that there's work. I mean, I'm just finishing a PhD. I understand what it's like to be in school, teach, work, have a family, and everything else that goes on. And I know sometimes you just can't get it done for whatever reason. So if this is a once in a while mishap, not frequently, I'll work with you, okay? And just, send me a message, all right? Now, our classes start at 3, and they probably are going to get out about 5, 10, 15. Now, I have a question for all of you. I prefer to go right through without a break. Now, if you have to go to the bathroom, you need to get something to eat, something to drink, just get up and get it and come right back. Now, what that does, it gets you out a little bit earlier. Do you want that, or would you like a break in between?
I like to go ahead and get it done and over with.
Yeah, I'm fine with going through as long. I mean, if I can get up and use the bathroom and come right back, or this.
That's fine. I don't care if you eat, you drink. I mean, some of you are coming from here and you haven't eaten yet. Even breakfast hasn't been eaten yet. I get that. I have no problem with any of that. Okay.
Yeah, I'm fine either way.
All right. That's what we'll do. Now, the 1 week, and I've been said, well, yeah, professors asked us before, and then when they go right till 5:30 to the end of the class, and we really didn't get a break. Well, maybe one class, and that's week 5, and it's cardiac respiratory. It's a huge, impactful week. That is the basis for all of your NCLEX SEs everything when you talk about heart and lungs, right? So that is one that may, all right? But I will let you know even before we start the class. This is the one. This week, there is a discussion question. So you need your first one up by Wednesday. I've been asked, do I mind if you do it all in one day? It doesn't matter to me. You don't have to do one and wait. That's something that if there's something there that you can answer to that's appropriate, fine. Just make sure that you do your APA with it, okay? Give me some references. Now, again, submit your work on time. Now, late work is because you talked to me, something's going on. I can give you another week. I can give you some days. I can give you what, we feel is, good for you, that works in your benefit. Because I know life shows up. I get it. Now, if you haven't talked to me, that second week that it's open for you, it will be a minus 10% deduction. Okay? If you've talked to me, I won't deduct it. But if you don't, I will. Okay? And that's the way, it is written down for that. Okay? Attendance. Now, make sure that you come to class on time. As I said, 3:01 is 15 minutes late. It adds up quickly. And some students have gotten those 20% letters and decreased a grade. I'm sure you know somebody at your campus. If you have to be out, if there is some documentation for that reason, please give it to me and I will forward it to Dr. Brown, or you just send it to both of us, okay? If your absence is justified, we won't give you that decreased letter grade with 20%. Okay, very important to remember that, all right? We want you to sign in your name as known by Fortis. A lot of times, this is women I'm talking to. Their last name changes back or forth. Whatever Fortis knows you as, make sure that's what your last name is showing, okay? You cannot be in a car, whether you're a passenger or a driver. I've had them. The reason why passenger is because you could, do something and distract the driver, and it's just dangerous, okay? When you come to class, don't be in jammies or, just be appropriate. I don't care that you wear a uniform. You don't have to. I'm in a tank top. I live in Miami, so that's what I wear. But, I'm appropriate. I'm covered. And that's all I want for you. All right. Make sure you're on camera. All right. Again, one of the other things with attendance that I don't know if you've been explained this before is attendance is not just you showing to class. It's doing something within the Canvas shell. You need 2 points of going in there. Like this week, you've done technology quizzes, discussion question. That's 2 points right there. All right. So some students want to work ahead. The only thing I leave open is NCLEX questions. You can put them in whenever you want. Now, make sure though, every week, 2 places you've done something. All right. If for 2 weeks in a row, you didn't put those 2 points of references, even if you've been to class, they can drop you. So very important entering stuff into Canvas. And I wanted to really stress that. There is no makeup for attendance, okay? There only is that you can explain the reason why. So, of course, there's attendance is done. It's listed on the Zoom. I go by a Zoom log. It has all of the timestamps, et cetera, et cetera. And remember, that 20% deduction is real. They will start sending little messages out at 5%, 10%. You can get to 10% with little 15 minutes coming in early, late, or leaving early. It can add up really quickly. So if you want to know where you are, let me know. And I know if you're getting there, I'm going to say, hey, wait, you really want to be late? You could go over this. Okay, so it's your child who's sick. If you take him to the doctor, please give me a note. I will try to work with you. I will try to help you. So one of the things is being organized. You know, what do I need to do and when? Remember, the syllabus is your Bible. Whatever week that is due, that's when it's going to be due in the grade book. And your grade book is all set up for you. Okay? CJ Sims, we don't want them be done until they are in the modules when they are due. Okay, CJ Sims is week 3, 4, 5, 6, 7, and 10. All right, so don't work ahead. They can't be done. And I'll tell you why. It's because Darlene, Dr. Brown does not want that. Okay, so we will be giving quizzes at the beginning of the class. Next week's quiz is going to be on this week's information. So what does that make you do? It makes you go back and review this week. And that's the purpose of it. I could have done it on next week's information, but I think that's not, I don't want to do it that way. So I'm not. That's it. I will say no more. Make sure that you talk to me. Let me know what's going on. Okay. If you have any issues at all, please let me know. If you don't understand, let me know. If you need help with math, let me know. I will work with your time schedules. We will work out a time. I do things in evenings. I do it in afternoons. I don't really care for mornings, very honestly, but I can work with you, okay? I'm not a morning person. I worked night shift for 25 years, okay? That's a little bit of me. As I said, keep logging in. We know, checking things. Again, my announcements, I don't put a lot. If you see one, they're usually very important, okay? Make sure you go in, look out what's going on. Have my phone number in your cell phone. In case your computer dies, you have that cell phone there. And it's 305-951-8055. So in case something goes on, you know, and you can't get to me, please call me, text me. Come to work prepared. We are going to first go over a PowerPoint. That's the way I teach. And I'm going to tell you the stories all behind them. And then as soon as that's done, I'm going to do a Kahoots. Kahoots are anywhere from 30 to 60 little questions. And those Kahoots are all the concepts you're going to see on quizzes, exams, HESIs, and your NCLEX. It is such a good learning tool. I've been really fine-tuning them for several years now. And I still, according to last semester's HESI, change some of the concepts and add concepts, okay? If you need any sort of tutoring, please, I'll do one-on-one, three-on-one, maybe one campus. If there's something going on, let me know, okay? I'll do it before class. I could do it after class. It doesn't matter. I can do it at another day. You let me know what you need. And this is what our grading is. Now, CJ Sims are 6%. You know, that should be an easy 100 for all of you. You need to score a 90 and above to get it that 100%. So, you know, I think they're great. You start to think on them, and I've reviewed them and I actually really like them. The other 6% is this pediatric assessment project. This project, I'm going to mention it several times, but I'm going to start your brain working right now. I want you to choose a virtual person, child, any age. Pick a diagnosis that a child might have. For instance, I was talking to Rainier, talking about infant RSV. Now, what do I want with that? There's 3 parts to it. Tell me what RSV is. Number 2, there's a pediatric assessment page. There's like, I think 9 pages or something they're telling me it is. But it goes over all the systems of the body. And that assessment should reflect what this infant with RSV is looking like. And then in the end, you will see some Erickson and Piaget theorists, which we're going to be starting to talk about those guys, that you put them in there, and then nursing diagnoses. very important to put there. This is something that when you pick a diagnosis, you let me know. I have to give you approval for that. I don't want all RSV. I don't want all asthma. I don't want all autism. I like a variety, and I want you to teach me something. I love it when a student picks something that's like little, and then I don't know what it is. And then I get to read these assignments and learn something. And students, there's always a couple every quarter that does it for me. So I enjoy that. So think about that pediatric assessment assignment and what you might have it at, okay? So you know that the unit exams, quizzes, HESI, all of them have to equal a 78.0. Once you get that, you can add in the rest of your assignments. I mean, you could go from a 78 to a B very easily, as long as you give me, 80s in all of your homework quote assignments. Now, we do something with the homework just to show you how it does look at your grades and what does it do to it. Well, homework grades are turned off right now, which means you're going to be doing things, no change in scores are going to be happening. Then all of a sudden on week 6, I'm going to turn them on. And you're going to say, wait, my grade has changed. It used to be, and oh, why is it? And the same thing's going to happen when I turn them off on week 8. Hey, my score went way down. What happened? What did I do? And what that is I'm showing you how it, if you don't get homework done, how it can reflect upon your grades a lot. I've had several students fail because of homework, and they had like an 84.5 in a course. And because their homework wasn't done, especially that pediatric project, they failed. Homework fails. And that's on you. I will send you messages. If it's something that you're late because of something, again, just talk to me, right? All right. We know about quizzes. They are at the beginning of class. They're changed every quarter. I change them myself and give them to all of the campuses, all of the professors. So these quizzes will be changed. There are 10 questions, and you get a minute and a half for each question, which is just like your NCLEX, okay? So we will come into class. I'll do a brief announcement because all of you will be like, I want to get this quiz done. I want to get this quiz done. And you're not going to listen to me. So once the quiz is done, then we will talk about, what we're going to do for that week. And you're going to get your grades, right then and there.
I have a question real quick.
Sure.
Sorry. So if you have ADA accommodations to get extra time on the quizzes and exams, how would that be added to your stuff?
You would be given extra into the quizzes. I need a letter. Send it to me. Anybody with accommodations. I've received one already.
Okay,
So
cool.
just send it to me. You'll get extra time on your quizzes. And I will make sure Dr. Brown has it to make sure that they're on your exams.
Okay,
absolutely. Perfect. That is your time. You earned it. It's yours. We will give it to you. Okay.
Thanks.
Oh, you're really welcome. Exams are on ExamSoft as normal. You will be on Zoom. I don't need to see those uploads. If I don't get a grade, I will say, hey, did you upload it? I'll send a message. I cannot give you your grades as we do them. So you guys are on Monday. And unfortunately for you, there's a class on Friday night from 8 to 10:30 at night. So we don't post grades till Saturday, about 1 or 2 in the afternoon. Okay. I know as it gets to like exam 3 and like you are on eggs and whatever, I'll say it's okay, you're all right, but I can't tell you a grade. Okay. But I understand that emotion, working so hard, thinking you did okay, but you need it validated. I get that. So I'll work with you, but I can't tell you grades.
Can you tell us if we passed or failed or not without giving us a grade? Just if we email you, you can be like, hey, you passed or hey, you failed. You don't have to give us a grade though, just so we have some sort of relief instead of like mentally like beating ourselves over it.
Sometimes even if everybody passed, I'll come on and I'll say everybody passed. I also, the one thing that I do is anybody gets 100, I will tell you right away. because I think that everybody needs to commend you upon that. So that's one thing I do. And students do get hundreds on these exams. If you study the Kahoots, study the PowerPoints, and study the study guide that we give you, and listen to the reviews over and over again. I mean, I think students are having nightmares hearing my voice after they have my class because they keep putting the review on over and over again in the car, while they're going to sleep, while they're sitting, eating, et cetera, et cetera. So if you do what you're supposed to do, you should be getting that. Now, there are times where all of a sudden your computer stops working. It could be there's a hailstorm. It could be something going on. Don't try to continue. Immediately stop and email me, message me, okay, in Canvas. And the reason why Canvas, it puts my timestamp there. On my phone, it's not as easy to show the timestamp. So if you do it in Canvas, I will say, hey, there was a problem here. If the exams are timed, most of you do okay with it. I mean, even the ones with accommodations. And those with accommodations, we're going to have to talk offline about when we're going to do the exams. Are we going to do them in class, start before, or after? So whatever. We'll figure something else that works with you, okay? We'll make it work. If something's going on and you can't take your exam that day, I need to know before it as much as possible. Also, if you have somebody on the campus, Cookeville does it a lot, where you take your exams on ground. I need the faculty from your campus to email me. I don't contact anybody, okay? And then I could see who they are, and I could talk to Stephen, Professor Literal, Dean Literal, and say, hey, okay, this is one's doing it, all right. And I have to give an access code. So if I don't get that messaging, you don't have an access code, you can't take an exam, okay? When we do exams, no hats, no earbuds in at all. If you have to wear little ear for noise, you need to show them to me. Show me if there's any Apple Watches, etc. Show me your area. And hopefully you all have a whiteboard by now for your math, okay? If you don't have a whiteboard, use a gallon baggie, put a white piece of paper in it, get a dry erase marker, and you could write on it and then wipe it off with a tissue when you're done. In the meantime, until you find a whiteboard. Usually you find them in the dollar store is where we've been finding them, and students have told me about it, okay? So try to get that. And that's in preparation also for your NCLEX, because you can't bring in paper. So it's something that has to be erased, okay? So it's getting you ready. Everything we do is getting you ready to sit for your NCLEX. You know about the late policy. In exams, if you didn't notify me before the exam you weren't coming, you will get a 10% deduction. A 10% deduction. That means you start with a 90. So something's going on. Let me know before. We can reschedule it, depending on what's happening. You're sick. All of a sudden, you're in the hospital. Your kid, an accident. All different things have happened. Trust me, a lot of different things have happened. Just let me know, and I can arrange them for you. Again, how many times you want me to tell you? Tell me before something is due, what's going on. I'll work with you. Again, if you want anything, just let me know. I'm here. Homework, make sure you do them on time. I like to have a piece of paper. You all, I know you've got calendars on your phones and your computers, and you just put in whatever's due what. Whatever it is to keep you organized, You need to be. And again, I will be sending these messages out, these reminders, just to let you know. You know all about late work. I don't have to tell you anymore. NCLEX questions. Make sure you do the proper questions. For instance, the first NCLEX question, which is due week 3, is on growth and development. It's not in the pediatric section. It's under growth and development. Okay? There is a different one there. You'll see it when you go look for it. because growth and development's telling you all those little things that kids do and when do they do it. What do they do at 2 months and 5 months and 6 months, 8 months, etc. Okay? They must be turned in properly. That little green square there, do not send me something that looks like that. You need to send me the like 4, 5, 6 pages, and I can look and see exactly what you've done. If you don't, the first time, I'll put a 0 there. You're not going to keep the 0, but I'll put in a information, instructions on how to fill it out properly. And if you still don't know how, let's meet on a Zoom. Takes 2 minutes. It's very easy to show you, okay? NCLEX questions you can do over and over and over and over again. And the rest you can't, basically. CJ Sims, I need just the place where it's the screenshot with your name in the top right corner and it shows me a grade. And then I will be putting your grades in from there, okay? Any questions with that? Let me know. At the end, week 8 and 10, there's a practice and an assignment exam. They are through the modules. There is 1 attempt only, okay? Now, that's the paper, your assignment. That assignment, again, make sure, just like you're doing, you know, your discussion questions, make sure it's APA. If you don't understand what a citation is, I put little comments on all your discussion questions, and I usually give you some more information about the topic, okay? If I say no citations, I will show you a little bit, you know, the parentheses with what it should look like. I'll put it there. If you still don't understand, let me know. And references, try to put them in the best format that you can. Remember, Purdue OWL is this great website that you can use, or use your LRC. They're always there to help you. Always follow the rubric. Try to get newer information that you're using, nothing that's like 30 years old. I mean, what I knew 30 years ago in nursing, most of it doesn't, you know, it's all changed. So try to get me the newest stuff that you can. So the quizzes, you're going to go in through your modules and take them very simply. And we know the exams is going to be through Zoom and it will be on ExamSoft. Your HESI, you will find out later on. Now, most of them, I don't know about Salt Lake City yet, but most of them are done on campus. And it is, you know, they will write the schedules. If some of them have to be done in another manner, we did them on Zoom in very small groups. And that's something that if you find out that your campus is going to do that, we're going to, in the last, you know, couple of weeks before, we'll be making up schedules for you so that you can plan your time. And it's usually around the time of the class. Remediation. This is just like you've done before, how many hours you have to do. I want you to know the mean HESI score in pediatrics was above 900 this quarter, all the way around. And how did they get that? They listened to me. They listened to the Kahoots. They followed the PowerPoints. They reviewed those exam study guides. And I've got 100-question Kahoots specifically for the HESI. So I've got it all there for you. You've just got to put in the work. We know you need your ID, your license, or your Fortis ID when we do our exams, okay? You know, and these questions are put here because this is sort of how we think about things. You know, it's like, okay, you didn't get your assignment in. It'd be just like you didn't get that treatment done for that patient, but you didn't tell anybody. You see what I'm saying? That's the way I want you to start thinking. You know, yes, it's school, it's assignments, but reflect upon your career. You want to be nurses, you want to be professional, you want to be able to do what you have to do, you know, and take care of your patients, right? So again, communication. Any questions there so far? Have I totally confused you?
So you said about when would we go on campus to take a test? Which
It's
test?
your HESI week 11.
Okay.
And the HESI week 11, there is no class.
And then
Okay.
the other question is I must have missed it. What is a cahoots?
Cahoots is a game, and we're going to play one today.
Okay.
And
Sorry.
you go to, no, please, if you don't understand it, you're in for a treat. And all of you compete against each other. And there's always one who wants to win all the time. Now, I do not go and look at who scored whatever. That's not the purpose of the cahoots. The cahoots is I explaining, actually, again, make you think about why those answers were what those answers should be. You'll see, you'll enjoy them. I've never had a student not like them. In fact, they're saying, give me more, give me more. You can do a lot of concepts and questions. So, and that's what I do. So let's go ahead with our PowerPoint. Now, if you notice, I usually put them up by Sunday. I will have them, in your announcements. My mouse is being really picky. I guess I have to use my finger. Okay, so you look at this and you see it's chapters 26 through 30. There's a lot, right? 26, 27, 28, 29, 30. I mean, there's a lot of them. So I took this PowerPoint and broke it down to some key concepts that you need to know. Now, when we talk about anything with healthcare, there's always things that the national government, healthy people is something that I had no clue what it was all about. And then I went back and started my BSN back in 2009 now, 2009. I was 50 something, decided to get my BSN, MSN, and then PhD. Who would figure that? But all of a sudden they have me writing all these papers. All the papers are on healthy people. There's healthy children, healthy adults, healthy elderly. All the different areas are being covered. So in children, what is our focus? These are areas that are deficient that we need to get better. So, I mean, and these are all of them. Mental health is big now in all areas. Nutrition will always be an issue when we talk about children. Children don't eat right, what is the best food to give them, et cetera, and how do we measure if nutrition's working? We're going to be going on that. Oral health is a big thing. Physical activity, get up and go outside today, right? Because everybody's there on those computer games. And of course, as you get older, sexuality, always safety and injury prevention. So these are things that you're going to see as you go forward, if you go forward in your nursing degree, in your BSN, MSN. Some of the problems, healthcare problems, obesity. I mean, children, as I just said, a lot of them don't get up and go out and play, whether it's their environment where they live, or it's just they want to just play their games, right? It's they're sitting there having a snack and they're just gaining weight. And what's happened is these school-age children are becoming overweight and developing or can develop in the near future type 2 diabetes. We also know injuries, children being in the proper equipment, doing things like bicycle helmets, like if they're in football or soccer or whatever, are they wearing the proper equipment? When we talk violence, it's going to be lateral with children, could be adult to children, and vaping is a new one, where everybody's now vaping, and the lot of side effects are coming from that. And again, we are looking at mental health. I mean, look at all these things, the potential for injuries here. Suffocation, guns, swimming, hot stuff on stoves. I mean, I have a 6-year-old grandson, and by age 2, he was doing front flips in my pool because I was not having a child that come to my house that frequently, not being able to swim. And even though he swims, he will not go into the pool without asking permission first. And that is part of, health safety about water. Okay. Now, which kids are the sickest? Well, these are listed as your sickest. Now, prematurity or very low birth weight or low birth weight. That means those children born at a pound. I think the smallest child I saw was 375 grams, born at 23 weeks gestation. That child was little, little, little. And the amount of issues that can occur from that are amazing. I worked in the NICU, the cardiac ICU, and the last 10 years were in the emergency room. I was a trauma junkie and just loved being that person in charge and keeping it all together and flowing. That was me. Children in daycare. Well, why would that be a high risk? Well, I call it swapping spit. What do children do in daycare? One toy in the mouth to the next kid in the mouth. Because how do kids explore their environment? In the mouth from very, very small. If you're in poverty, homeless, you're not eating right, do you have proper, being able to clean, brush your teeth, electricity, all of those things we take for granted. Not everybody has them. Immigrant families, they're afraid to get medical care because they're afraid a lot of them will be deported. I've seen that here in South Florida. If I got an immigrant mother with a child and they were in an ER, and I did triage a lot, I would be worried because I know that child has been sick for a while. And if the kid is there, they're really sick. So I would always keep my eyes open to that. Children with those chronic medical conditions, cerebral palsy, respiratory problems, right? All of these things can have a lot of things that we need to do for them. And of course, psychiatric illness. And you're saying children, psychiatric? I have seen some crazy things. A 6-year-old manic depressive would come in, we put him into our room and he would defecate and smear it on the walls and himself and, just not normal stuff. And usually it's because they've grown and their medicines, they needed up doses, etc. So children do have psychiatric problems. And then those people who have some sort of barrier to care. It could be as simple as I couldn't go to the doctor because I didn't have that $5 deductible, that copay. And that is a reality. Many of them that have to go to the ER, but didn't have the money or somebody to bring them to the ER. So those are some barriers that you see. Now, infant mortality. The first 28 days of life, a baby is called a neonate. Okay, that's neonate mortality. That's the first 28 days of life. And then after that, up to 1 year, they're called infants. I want you to know that the United States is not where it should be. They lag behind. They really need to do more to help babies be born in better conditions. A lot of it has to do with prenatal care. And there's been so many changes done in the newborn ICU, but more need to be done. And that's just nursing and medicine. The changes that I have seen are incredible. And the outcomes are so much better than what they were. So childhood mortality. Well, if you have a kid who's greater than 1, the kid has now gone through the first year. It's gotten the vaccinations. It's more immune system is better. They're harder for something to get them for them to die. Okay. We know that the 1 to 3-year-olds, toddlers are what I call my dive bomb kids. They have absolutely no fear and jump off couches and miss the other couch, land on the floor, bop their heads, have concussions. I've seen them climb up dressers to get to the TV. I've seen all sorts of crazy stuff, but it's a lot less than the infants. Ages 5 to 14, they're more settled. They're not doing risky behaviors, but then they become adolescents. Adolescents tend to do more risky behaviors because, you know, they're grown up now. They know what they need to do, and they want to have all of the privileges with no responsibilities. And you're going to see injuries. Motor vehicle is #1 of all injuries. And now an adolescent is going to be driving also. So part of it. You know, and suicide is a big thing. You talk about adolescents, and we're talking about children who are all about body image, you know, and what they look like. And if they don't have a good body image, they are not going to be happy. And there's just so much, and we're going to go on that more as we get to the adolescents. These again are those children, you know, that have increased mortality. We sort of talked about it. So pediatric nursing. Now, this is probably the reason why many nurses do not go into pediatrics. It's because you're not just taking care of a child, you're taking care of the family. And a mother and a father, a grandmother, a grandfather can be overwhelming. They could be hard and difficult, you know, to work with. You know, they could be overbearing. I have gone through, I can't even tell you how many families. In fact, if there was a rough family and they needed a nurse to take care of them, guess who that was? That was always me, because I could sit and be patient and talk with them and get them calmed down. Okay. Now, family-centered care is pediatrics because, as I said, it's just not a child, it's the family. Here in South Florida, the culture is big Hispanic. When a child goes to the ER, you're going to have mom, dad, grandma, grandpa, aunt, uncle, best friend, niece, nephew, etc., all going with them. So now you've got the family that you must work with. Okay, and that's a reality. So I'm going to tell you how to deal with that as we keep going through this course. So family is the constant in the child's life. That's all they know, especially younger kids. They don't know other people. All they know is what they have been around, all right? That, you know, family members, we need to think about the other ones, whether it's the sibling at home while you have a child in the hospital. We need to be thinking that poor sibling feels neglected, right? I used to send home coloring books and crayons to those kids, you know, to say, here, color this and bring it back for your brother, the sister, whatever. So you're always thinking, mom hasn't taken a shower. I'm going to sit here, go take a shower, because they didn't want to leave their child. You know, things as minimal, as simple as that are huge, okay? So what is a family? It's whatever they say it is. Is it a mom and a dad and a child and a couple other siblings? Or is it a stepmom and a dad? Or is it a grandma and a daughter? Or is it adoptive? It's all different. So the definition is whatever they say it is. That's their family. The pediatric nurse, as you can see, you're working with a family. You are going to be the psychologist. You're going to be the listener. You're going to be the teacher. You're going to teach them how to take care of their child. And of course, anything with disease prevention, promotion, we're going to be trying to educate. And that's part of it. And it is a lot about that therapeutic relationship and that listening, right? And seeing what's going on with them. We try in pediatrics to give as least pain as possible. You know, in the adult world, you go in, get an IV, they stick it in with no concern, you know, that it's not numb. And this is like a huge gauge needle that we're sticking in there, right? In children, we'll use numbing creams and all different sort of things to decrease the amount of pain that we inflict, okay? My dissertation is on school-age children's attitude and behaviors towards injections. How many children are afraid of injections, whether it's a shot, a needle, or stitches, whatever, right? And how many, you know, think they're going to get a stitch and run in the opposite direction? And some of them like, okay, here, do it. You'll have both sides. But What happens in those that are afraid of needles, they become adults and it becomes a needle phobia, right? Now, where does that needle phobia be projected to? Their children. And what happens? They're not going to get those disease preventable immunizations. So now we have a lot of these diseases coming back because of lack of immunizations. And a lot is because of a needle phobia. So that was my dissertation, and learned a lot from it. So health promotion and religious and culture. Well, we've talked about family. I don't have to tell you anything more about it. And we know that you need to be able not to understand, but to give that parent the ability to believe what they want to believe. Okay. Very simply, you have to sort of understand, social. Is daddy in control? Is mommy in control? Is it the grandma? I mean, in the Hispanic population, I found out abuela was the most important person. So every culture has something different there. And then what about religious? What do they believe in? Is it dietary restrictions, or they have to pray a lot, or what? Okay. They're young, they need to be baptized, they're in critical condition. Thinking about those things, and just giving those parents the opportunity to do those things that they feel they need to. Okay. We know that there's a whole bunch of influences that come around: schools, peers, community, social media. That's all part of it. We know that children are a part of their race and ethnicity. And if they are in poverty, they're going to look at things different. All of these things, mean that when we're talking to them, educating, we got to get on their level and talk in a manner that they can understand for you. So, a frequent health problem of migrant children and adolescents in the United States is what? Migrant children coming from out of the country. It's tuberculosis. It's one of those things that we, as this country, we do a lot of TB testing, right? Other countries don't. And a lot of immigrants, they come here in whatever means they can, right? Now, understanding the cultures, like I started to say about what are their things? What are their physical things caring for them? Is it a culture where you can't put a man with a female? Or is it part of undressing and being careful about what you're undressing and covering other parts? Allowing for prayers, allowing for, the medicine man or whoever it is, giving them that opportunity to take care of it. What causes illness? Do you ever hear if you go out in the rain, you get your hair wet, you're going to get sick? Or don't go outside with wet hair. Don't go to bed with wet hair because you're going to get sick. I've heard things like you have to walk around the floors. You have to have socks on because the cold floors are going to make you sick. I've heard all different things about hot and cold and rain. One of the things, I've actually been involved with some sort of, I don't know, voodoo, I don't know what it was. And it was with actually an adult, and doesn't mean it can't happen with children, that they were doing some sort of whatever over this gentleman he was. And I was pregnant, and they made me put a quarter, tape it to my belly button because they didn't want evil spirits getting into me. I taped my belly button. It didn't matter, right? But it made them feel better. And the craziest part about that situation, that gentleman got really better the next day. And in 2 days was transferred out of the ICU, which he was a really sick gentleman. So does it work? Not for me to say, right? Another thing we have to be concerned about is things like, as I said, baptism. Having a minister, a preacher, a priest, a rabbi, whoever come in and see their children and bless them. That's important to many parents, and we need to give them the opportunity. What about Jehovah Witness and blood products? What are you going to do if you have a Jehovah Witness who has a baby in the newborn ICU, and babies don't start making their own blood till like 3 to 6 months. So the cells die, right? So what happens to the hemoglobin hematocrit? It goes down, and they're not making any more. And in newborn ICU, you've got to take lab work in order to look at electrolytes, et cetera, to make sure that the hyperal is correct or this or that, right? So you have to give blood. Now, a Jehovah Witness person will never sign a consent for blood, and you need a consent. So we send it on to our risk manager, and they go to the judge, and we get a court order. Now, you can give blood to that infant. Now, does that mean I'm going to take that blood bag and rub it in front of those parents' face? Oh, absolutely not. As I said, I worked a lot of nights. I've done some days too, but mostly nights. I would say when you leave, I will give him the blood, so you don't have to see it. You can call me at this time when I'm done to let you know how it went. Or during the day, step outside, pull the curtains. I will put all the blood, take it down. Nothing's hanging, nothing's in sight. And even the tubing is covered with a blanket. And all I would do is look at the hand every now and then. Of course, you could check the IV site, right? And I just do that. And everything was covered. So there's ways of doing things without shoving blood in the face of a Jehovah's Witness. That is a sacrilege to them to get blood. It's like giving somebody else's soul, is what I've been told. And you don't want that. That's just, that's what they believe in. You don't have to. But you need to respect it, okay? Food, vegetarians, they don't eat pork, they don't eat beef, they whatever. Make sure that we do it. Treatments. Some of them have their own things. They drink teas, or they have different poultices, natural remedies. I mean, my husband is the man of ginger and garlic teas. He's a Jamaican man, and he believes in this for colds and or smelling the steam, or all different things that are used, natural remedies. And there's nothing wrong with them as long as it doesn't interfere with what we're doing in medicine. The combination, there's not a problem with that as long as they work together, right? So as I said, nurses, we're there. We are there to support them, counsel them, and help them sometimes with decisions. And we do a lot of this because we know what we're doing through whatever research or what evidence-based practice is there. So the leading cause of death among African-American boys ages 15 to 19. So remember, they, at this point, they are risk takers, right? So what would be the answer? It's the firearms, right? Absolutely, that's exactly what it would be. Because now let me pick up daddy's gun and check it, and boom, it goes off, right? We've heard how many stories on the news about that. Okay, and now talking about growth and development. I think pediatrics, a lot of it has to do with getting an infant born at 7 pounds and watch them by 1 year be 21 pounds, and they go from not lifting their head to walking and running. It's quite amazing. It's the growth, the development, how it matures. It's differentiated, but it's interrelated, simultaneous, and ongoing. And a child gets just more and more and more. So they're walking, but they're, sort of, wobbly. And then they get more and stronger, et cetera, et cetera. And that's all growth and development. So there's different words that we can use in that. These are in your book, the directional trend, or sequential trend. The sequence is you lift your head first, then you roll over, and then you crawl before you creep before you walk before you run. All of those things go in sequence. Now, it doesn't mean you can't skip something. There's some children who never, do one thing and all of a sudden they're running. They could be creeping and never crawling. All of these things, as long as they're moving forward, we're doing good. So their metabolism. Did you notice that I sent you, I'm pretty sure I did, a worksheet about vital signs for children? I did that.
Ms. Bogart, sorry.
Yeah.
So whenever I try to get onto them, it says access denied.
Yeah, it did that to me too.
Mine says
All
the same.
right, I'll repost them. Thank you so much for letting me know. I'll
Every,
redo.
yeah, like almost everything under that tab and that announcement says access denied.
Okay, I'll redo them. I'll redo them and I'll send them to you. Okay, if not, I'm gonna have to send it like as a message in there instead of an announcement. All right. In fact, I think that's what I'm going to do. It'll get it to you. But thank you for letting me that know. Thank you. So metabolism, heart rate, breathing, right? That's metabolism. Now, when a baby is born, a normal heart rate at sleep is 140 to 160. They're crying, it could be 200, their heart rate, and that's normal. Respiratory rate, 40 to 60. Now, as we get older, the number comes down to get to where adults are, 60 to 100, 12 to 20, right? That's the normal thing. Blood pressure. What is a blood pressure of a newborn infant? A full-term newborn infant, 60 over 40. That's that 120 over 80 we see in adults. So you can see that number goes up as we get bigger, okay? We know that children who are born, they don't hold their temperature. They've been floating in water, so we need to keep them warm as infants. As they get bigger and they get, more fat tissue on them and muscles as they start to grow, the thermoregulation isn't as big as a deal. But what do we do on a brand new newborn just born? We put a hat on them, put them underneath a warmer, right? And then we wrap them up in how many blankets? It's because of thermoregulation. We know infants sleep a lot, and as we get older, they sleep less. We wish they would take 3 naps a day still, but they're not going to do that, after a certain age. And the single most important thing on growth is nutrition, nutrition, nutrition. If a child is not eating correctly, this child is not going to grow. They're not going to gain weight. Why do you think every visit to urgent care, ER, doctor's office, anytime an infant child is seen, we do a height and we do a weight? Why? The biggest reason is, are they getting enough nutrition? And then we could go into, do they have enough thyroid hormone? Do they have enough growth hormone? And it goes on and on and on, all the reasons why. And we'll learn them as we go on. But we know that nutrition, nutrition, nutrition. They're eating, they're sleeping, they're gaining weight, they're doing really good. We know children are all different. You got that easy kid, you start out with the first child and they're easy and put to sleep and they're not a bother. And then you get the second kid and they don't want to go to sleep and they're harder to settle down. And that's just part of who people are, right? Now we're going to be going over these theorists. There's a lot of questions on your first exam and quizzes on these theorists. These theorists basically describe human nature, okay? So we'll be going over that. I'm going to send you a PowerPoint all about that. The front of it is about them, and then the second half is more growth and development. But I think if you see it more than once, I'm going to be describing these as we go on in the lectures next week on infant, toddler, and preschoolers, okay? But just briefly, we know Freud's all about things with sex, right? So it's oral, everything in the mouth, suck the fingers. How do they self-soothe? Something in the mouth, right? Anal, potty training, toddler stage. Phallic, they're starting to see what they have down there. Those are your preschooler. Then the latency period is what we call same-sex peers. And then again, it goes into the genital stage and adolescence, the exploration, sexuality, et cetera, et cetera. Erikson, probably the most tested theorist of all the theorists, Erikson and Piaget. And you need to understand what they mean. So when you're an infant, what do infants do? When they want something, they cry, right? Mommy or daddy or somebody goes, gets them. So they have a trusting relationship. Their needs are met. That is trust. Well, what about that whatever sort of home where the baby cries and nobody goes ever. That baby just has to sit there and cry, cry, cry. Could be for whatever reason. That child is in mistrust. So that child never believes in trusting anybody. And it could go on through life that way. The toddler stages, 1 to 3, autonomy versus shame and doubt. Well, autonomy is being autonomous, doing for themselves, right? Toddlers like to do things, but mommy, daddy, grandma, grandpa, oh, be careful and don't do that. And you're going to be careful. And here, let me get you and let me do it for you, right? That's the shame and the doubt. Because toddlers want to do it, but there's somebody telling them, be careful and don't do that. And you're going to trip and fall. And let me help you. Let me help you, instead of letting them try. That's what that means. As we get older, initiative versus guilt. They want to do things for you, but they're afraid they're going to do them wrong. And then the most tested, besides trust versus mistrust, is the school age, industry versus inferiority. School age children like to do things and be the best at something. They like to do it well, whether it's math, writing, soccer, swimming, running, whatever, right? That's industry. That's what something they do well. And they can't do everything well. So the rest of it is inferiority. That means I can't and I won't be able to, but school age children wants to do everything as good as they can. And then as we get older, it's the identity versus role confusion. Remember, they're going through these adolescence about body image. Who am I? What am I going to be? Do I like girls? Do I like boys? Am I going to be a doctor, a lawyer, an Indian chief? I mean, who am I going to be when I grow up, right? And it's all about this confusion, going from a child now becoming an adult, trying to change and figuring out what all that means. So basically, in a nutshell, that was your Erickson. Piaget, we really need to, have some pictures up. I can show you more, but it's all about thinking. It's all about, let's censor a motor. That's the young children. Well, when a baby's born, they don't know a finger in the mouth can soothe them. And all of a sudden, the finger slips in there and they start sucking on it, or that pacifier is put there. Oh, and they're soothing, right? It feels good. Well, then all of a sudden, they're able to grasp something because they're going to go through fine motor skills. And one of them is a grasp. And all of a sudden, they take that rattle and it moves and it makes a noise. And they go, oh, I like that noise. It's figuring things out so that the next time they want to be soothed, they'll stick their finger in their mouth. Or if they want to hear the noise, they'll do it again. They'll shake it again. So they build upon and they're learning stuff. And that's what all of this is. And it gets to the point in adolescence being able to figure their way out of a paper bag. As in, mom and dad won't let me go out because of this and that. What can I do to change their mind? And they're going to run 10 scenarios through, and they're going to keep doing it till they get what they want. So, and that's total understanding of their mind and figuring things out. And then there's the in-between. We'll go into it. We know that children start with cooing and crying. That's just part of what they do. And we know that all children do need a way to communicate. And we know it starts out with that cry or that coo, right? Now, Kohlberg's all about right and wrong. Kohlberg talks about doing right, doing wrong, and a consequence for each. And that starts young, but as it gets older, it gets into, well, I know it's wrong, but I got to do it. Is it worth the punishment? And if it is, they'll do it anyway. So they're starting again, thinking about right and wrong and how to do it. Now, what do kids do 24 hours a day? They play, right? And there's all types of plays, and you need to know what they mean. So we have socio-affective, they play with people. Sense pleasure, that means water, sand, dirt, mud. Kids love touching all that gooey stuff, right? Clay. Skills, building something by themselves or with others and pretending or playing games. This is all part of it. So we know play teaches children how to do things. It teaches them different things. I mean, How many of you had the kid who found something and then it smeared it all over themselves, all over the walls, all over everywhere? I mean, as part of the sensor motor development, that is, okay, I can do that. They don't realize that they're full of purple and now mommy's going to be upset because she's got to give the kid a bath now, right? But they had fun doing it. It's part of a learning process, okay? Because being aware, being creative, all of these things are part of play. Now, these 5 social characters of play are ones that you really need to know. Onlooker, I'm looking at somebody else play. Solitary, alone, I play alone. Parallel play, really popular for your toddlers. They play next to each other, but they're not playing together. Associative play is they're next to each other, using each other's toys, but not playing together. There's no outcome. There's no who won the game, like a checkers, okay? Cooperative play is 2 or more children playing together with a goal. Well, on the beach, maybe it's making a sandcastle. Maybe the older children, a board game, playing dominoes or playing checkers or whatever. They know there's an end to it. What do we want to do? So associative, there is no rules. It's unorganized. Cooperative is organized. Toys are great, right? What do we use toys for? Well, that tummy time that we all heard of, right? You get an infant, you want to put them on tummy time because you don't want the backs of their heads all flat because of, Sid's death, and we have to keep the bellies off, the children off of their tummies when they sleep now. So we need to have their heads rounded up. So what we do is we put them on their tummies and we put stuff in front of them. And what does that kid do? That kid tries to get there and get that toy, right? Tries to shuffle. So you are helping them develop the ability of motion, muscles, etc. And once they get it, then they can play with it and do with it what they want and then learn about that toy. How do we assess a child? Well, it depends on your age, depends on the condition of the child. You look at the child on the left picture here. That child appears to have cerebral palsy. So how would you talk to that child? Maybe a little bit more simpler than, let's say this kid is 12 years old. Maybe we would talk, a little bit simple so that they could understand and follow them. So understanding where the child is in their level of development is how are we going to talk to them so they understand us? Kids are born with all different things. We've heard of cleft lip, cleft palate. It's one thing we hear of, club feet. We're going to learn how to take care of those things. We're going to go over them. Or they could have a syndrome. If you hear about a syndrome, you always think, oh, Down syndrome, right? That's one of them, but there's so many more syndromes that are out there. It got to the point where I would always look up, like, what does that syndrome mean? And what's that syndrome mean? There are thousands. You just have to, you'll never learn them all. And I never did. And I know quite a few. Or again, some of them are drugs that the parent has to take. We know genetics is a big thing. It's a big influence. And we know that some of these things, we can predict outcomes and babies. So doing some sort of genetic testing, some of these parents might need it. So it's all of it can influence their development. We know anything that's ingested by mom or around her or in her can cause problems. And again, that genetic disorder, Down syndrome's, is chromosome 18, 21, 22 deletion, Q22 deletion syndrome is actually something called DeGeorge. It's knowing what does that mean? What does that mean for me taking care of the child? What do I have to look at? A Down's child, is it something I have to worry about with choking? Is it something with feeding? Is it hearing? Is it sight? Is it what? I need to know so that I can take care of these kids. The nurse needs to understand those things so that we can help parents, teach parents, help children, teach children. Children, even though they're nonverbal and cerebral palsy or autistic or whatever, there's some of that information that gets through to them. So I always teach my children. One of the things that I've done is, especially in working in the newborn ICU, you have children born, let's say cleft lip, cleft palate, or something that's different. And those parents are afraid to touch their own infant. If possible, I'll make them sit down. I'll wrap that infant up and put them in their arms. And I will say, oh my gosh, look at all that hair. What a beautiful set of hair. Let's look at those things that are good, and trying to promote attachment, because sometimes you have to. Just to let you know, with this picture here is the object permanence, pre-operational thinking. These are things you're going to have to know about. So I have put in the answer here and what those things mean. Now, object permanence starts as an infant. You take and give them a toy and you put it out, and then you hide it. That infant still knows it's there, and they go looking for it. Like a 1-year-old, you put their toys away at the end of the night. They know when they wake up in the morning, they can go out and they know which box it's going to be in, and they pull it out. That is object permanence, okay? So these are the other ones here for you also. So history, physical, remember HIPAA, always remember HIPAA. And the one thing that's crazy about HIPAA in pediatrics is if you are cognitively aware 18-year-old, you sign for your own consents. And now you must ask the parents. You have to ask the child if the parents can get information. So now you must ask, because if you don't, you're in violation of HIPAA, because you're talking about information and didn't get permission from she's not a minor anymore. They're legal age. They sign consents. Talking with parents can be hard, as I said. As I said, sometimes there's groups of them, and it's like, what group am I talking to? So you'll have parents who want to tell you everything that ever happened to their kids from birth. And really, many times, you need to know any big stories, but most of all, you need to know, why are you here this time? Is it the cough, the diarrhea? Is it what? Always be aware, and culture is a big thing. There are some cultures that you can't look at them in their eyes, or you must go to the father, not the mother. So just being aware. And I always would say, so who do you want me to talk to? I will let them tell me. I don't have to figure it out. The parents respect you when you say that. Always use silence, let them talk what they need to say, and, give them empathy. One of the things I've learned is, especially with young infants that are sick, and the parents, so let's say they're 3 to 6 months old, and, they got sick and whatever's going on. And, they bring them in, they went to the doctors, they've gone to urgent care, and now they're in the ER. And you say, Mom, you've done a great job. You must be exhausted. And are you working too? Let them know that you understand that they have done everything they possibly can, because usually they feel like they've done nothing and nobody's listening. And when you do that, you've actually built up a great rapport with that parent. So always remember, be empathetic. Now, never have a family member do any of your interpreting. Always get a real interpreter, whether a phone or one of your staff members, because the family will change the tone of what that person's trying to say. Okay? Kids, number one, how do you talk with kids? Well, first of all, you notice, she sat down on the bed next to him. Oh, absolutely. I would sit down. They'd be on stretchers in the ER. I'd be sitting in a chair below them. I'd say, wow, those are really neat sneakers. Or, wow, those are great blue eyes. Or, you got a Batman shirt on. That's cool. Now, all of a sudden, this kid, now, I'm not threatening. I'm below them. I'm not towering over them. Then I'm going to start to do things like, do you know where your eyes are? And they'll point to their eyes. And now we've got a game going on, don't we? And through play, we can get things done. I can have them play with my stethoscope, the blood pressure machine, the thermometer. I can have them push buttons, help me, and I'm going to get better vital signs, better assessment on the child that I have helping me. Usually it is the parent that you speak to, but again, get it down to what's going on now, so that we can figure out what needs to be done for that child. When we start history, especially when you're going to be admitted into a hospital, was it a normal birth? Was it a C-section? Were they, how many days in a hospital after birth? What do they eat? Have they had any allergies? Any medications today? If they have a fever, I want to know when I can give Tylenol again, right? Immunizations, very important question. You have a child in with an upper respiratory, 6 months old, you should have a child who's been immunized. And if they're not, these little upper respiratory things could be something a lot bigger than just a virus. And you'll have to protect yourself and others. So immunizations are important. And then, of course, growth and development, height and weight. Are they gaining weight? Are they walking by at least 1 month, 1 year old, maybe trying to take a step? My kids never walked at 12 months. At 15 months, they all ran, and that's normal, but at least they were trying to, right? As they get older, finding out sexual histories. This is adolescence. And I'll tell the parents to leave and do a little history with them, because an adolescent's not going to talk in front of their parent. And I don't have to tell the parent what they said unless they're going to hurt themselves or others. Okay? So, and sometimes that helps you get them the care that they need for that. All right? And, with family, know who the boss is, the one who's running the show. I always will ask the children, so how you doing in school? What's your grades? What's your favorite subject? When we start seeing they're getting C's and B's, well, we know, all right, why is that? Is that they're just slower, or they're not getting the attention that they need from parents? What is it, right? So it really helps. Unusual habits. You want to know if it's a blankie that soothes them, which pacifier, the only pacifier they'll use, or which stuffy animal is it that they like. Especially if a parent has to step out, go to work, whatever, and you're there alone with that child, you need to know what can soothe them, right? Very important thing. What do they do? And then, of course, how are these parents and children reacting towards each other? When you work in the ER and you're put them in a room and the door closes and they're sitting there on a stretcher, and you walk in and the parents watching TV on their phone, the kids on the stretcher, ripping the paper off, taking all those ear things, throwing them all over, opening drawers, you're like, that parent wasn't even watching this child, right? So we know that there's just no control on that parent. Dietary is important because we need to know what they eat, because we need to give them what they should eat, right? And we need to see, are they overweight, underweight, and what do we need to do for that? When we're doing physical assessments, you're not going to do what you do with adults. You're going to get the assessment that you can do when you can do it. For instance, if I have an infant asleep in a mother's arms, I'm going to listen to their heart and to their breath sounds. Because once they wake up, they're moving, they're wiggling, they're grunting, they're crying, and you're not going to hear it, right? And then every other thing will fit it in as we can get it. And that's the way that they are done. With children, as I said, when we're doing them for an assessment, let them know what you're going to do. As I said, let them look at your equipment, play with the equipment, take a blood pressure on you first, whatever it takes. Have them a part of it, and they will work with you, because now it's become fun. So if a painful procedure, even with all of these pain-saving devices that we have, it's still going to hurt a little bit, please be honest with the child. It's going to hurt a little bit, but I'm going to do everything I can for it to be as little as possible. And it will be gone really soon. You know, that honesty is all children really do want, okay? A lot of times I will examine children, and it's actually a program I developed at Nicholas Children. It's called Huggies. Help us give great injections efficiently and safely, which means hold your child while I give them the injection. They're in the arms, they're comforted. You give them the injection, they want to cry. They're in the parent's arms. So they'll have less pain, stress, and fear because they're not going to be crying as much because they're in mommy's arms. So having a child in a lap is a great place to do an assessment. Remember, all of those numbers are all going to be different. Remember that your blood pressures, etc., has to be according to their age. Remember, blood pressure cuffs that you pick has to be the size for that child. Do you know blood pressure cuffs come from 00 to adult extra large? And there's about 15 different sizes in there. And you'll have a baby who's like the baby up here, might be a 0 cuff. A premature might be a 00 cuff to fit on a finger like that. That could be their leg. So making sure that we do it, pick the right cuffs and place it on properly. And a lot of times physical assessment is a lot of just visual, looking at the kids. You can tell well appearing, sick appearing. It's very easy. You know, looking through the child, doing all the different assessments, looking at their belly, the inspection, the auscultation, palpation, you know, genitalia. And you're like, you know, they'll have it, yes, but there are different things that can occur. For instance, I've seen many a time fused labia on females where the labias are together. And underneath in there is the urethra and the vagina on this fused together. And it's not like you can rip it apart. They just put hormone cream on it and it just recedes. But things like that, if we see them, we can tell the doctor if the doctor hasn't seen it and make sure that they get the proper medicines, visits, et cetera, for it. We always check an anus on a newborn to make sure they have one. And as we get to GI, I'll talk to more about that. Looking at their back, their joints, their muscles, if they're moving. Older kids, you're going to have them check your knee for reflexes, just like they're checking yours. Infants, we do head and abdominal circumference, you know, immediately when you get on shift. You want that good assessment for that day to see what's going on. Increased head circumferences mean things. Increased abdominal circumference means things. And we need to relate that to that child's care. Taking a height on a child, you see that piece of wood that came down on that little kid's head? You know how many kids go crazy when I want to put that down there? They think it's going to bop them and hurt them. So what do? I show it to them. I let them touch it. And right next to it, there's usually like a number, which will tell you. And I'm saying, okay, I want you to hold it. And when you feel it there, let me know. And let me say, what's your number? My number is 7. What number are you going to get? And I made it fun. So now that they're doing it, they're having fun with it. It's not like afraid, boom, on top of the head, and they're going to be hurt, because that's what they think. As I said, blood pressure cuffs. Honestly, D is what I use on a lot of my kids, toddlers, preschoolers, because I can hold that leg, it doesn't hurt. I mean, a brachial artery, number A, I'm sorry, it pinches my arm. It hurts. I know it happens to kids. So putting it on that lower leg actually does help. And sometimes you've got to do 4 extremities, depending. And then pain management in children. Probably one of my pet peeves in nursing is that we really don't take care of our kids with pain. Somehow we don't think they have it. And these kids, all they'll remember from hospitalizations is that they hurt a lot, okay? We don't treat them, and a lot of times we don't give them enough of medication, we wait too long, or you don't do anything, you know, give them a hot pack, a cold pack, change their positions, all of these little things that they can do help. You know, we take these things for granted. Now, there's all sorts of pain things, but there's 3 you need to know. the faces, the wongs, and the numeric. So numeric is used by kids ages 8 and older. This is what you use for adults. From 0 to 10, what is your pain? 0's no pain, 10's the worst pain in the world. FLAC is used for your infants, kids who can't give you a number, can't look at a face and tell you a face. Or it could be an 18-year-old cerebral palsy nonverbal child. You can use FLAC. And what it does, it looks at the facial expression, the legs. A kid in pain, the legs are going to be moving if they're hurting. Their activity, or are they laying still and can't move? They're in so much pain. And then crying, and are they consolable? Can you console that cry? A child that's not consolable, that kid hurts. Faces is a kid. Now, you can use FLAC for your toddlers and the nonverbal. At age 3, preschooler, faces come. And faces is this one right here. It's no pain and the worst pain. You might see it from 0 to 5, or you see 0 to 10. They're all different ones. But a kid age 3 and older, up to age 8, that's when numeric comes about, can point to a picture and tell you how much they hurt. So there's also chronic pain. Think about sickle cell children. Think about rheumatoid arthritis. There are some conditions that are more of a happens for a longer period of time. Chronic, part of that, reoccurrent, that again is your sickle cell type thing. And there are children who are just chronically in pain. So we know it does affect them, and it can cause depression in children if we don't take care of it. Remember, children, they're not going to tell you when they're in pain. They're afraid they're going to get a shot, most of them, or they don't want the medicine. So no, I'm not in pain. I'm not in pain. Remember, there are cultural differences. I think that one of the things that I've seen with that is, you have a boy, let's say a fractured arm, and they come in the hospital with their dad. And, you want to give the kid a little bit of morphine because this break, they have to manipulate it to put a cast on. And the dad says, no, he'll suck it up. He don't need it. He's a boy. He's macho. And you're like, huh? Would you like a broken arm manipulated and a cast put on? So remember, culture does make a difference when it comes to pain. And telling them that one shot of morphine doesn't make them an addict, because that's exactly, they're going to get addicted on one shot. So just remember that. And remember, there are kids who are chronically in pain. There's all different things we can do to help pain. I mean, kangaroo care, that's what this lady's doing right here. I've watched kids bonkers in their isolates and their warmers, and they can't get comfortable, and their heart rates are up, and they're burning calories like crazy from all that. Put them on mommy's chest, the heart rate goes down, the blood pressure goes down, and then these children rest. It is quite amazing the difference between with this kangaroo care. I love it. I think it's absolutely great. Remember, a pacifier is one of the big things, because remember, how do infants soothe themselves? Self-soothing in the mouth, whether a finger or a non-nutritive sucking, which is a pacifier, okay? And of course, wrapping them up, giving them comfort, and then distraction for your older children. Give them something to color, put on a cartoon. I like stickers. I had stickers of all different whatever cartoons, and I'd give them to the kids, and they'd be really think that was great. And all of these things do help. We forget that there's just not those big guns as morphine. There's Tylenol, there's Motrin, and PCA pumps can be given to your older children. Those kids that are really a lot of pain, they can control their own pain. A PCA pump is a great thing to use. Now, we use EMLA a lot, and that little girl, why is she smiling? She's going to get her blood drawn, and she's smiling. That little clear plastic with that little white goop, that's a numbing cream called EMLA. They're numbing the skin. So when they go to stick the needle in, she doesn't feel pain and they just get the blood. And she knows that because apparently she's had it done before, right? Because remember, kids don't need to be hurt if we don't have to. And, you know, untreated pain is, can make them fear for the next time they come in. I mean, pain could be due to anything, absolutely anything. Ear pain, big one in children. They hurt, they cry. Circumcision's done now with just a pacifier on newborns, races, and you know, et cetera, et cetera. So, which of the following is an important factor for consideration in understanding the pain experience in children? Somebody answer that one.
It's big.
B.
Yeah, they're not going to admit it because they don't want the shot. They don't want the medicine. Absolutely. All right. So that was our first PowerPoint gone through. Any questions? All right. You're going to go to Kahoot.it.
Okay.
On your cell phones.
Which one?
You're going to go to Kahoot.it on your cell phone, and you are going to sign up and put this game pin right here when they ask for it. You're going to look at the computer, see what the answer is, and then you're going to press it on the phone, the color of the bar, the red, the yellow, the green.
I don't know how.
That person who did not know how to do Kahoots, were you able to get on?
Yes, ma'am.
Good. Okay, just making sure. Oh, we got a future NICU nurse. Cool. All right, I'm going to get started. You can ask me any questions at any time. You do not be afraid to stop me, okay? From a worldwide perspective, infant mortality in the United States. Infant mortality. How many neonatal deaths, infant deaths? You know, it is higher than other developed countries. We haven't really done everything we can yet, but the thing is that we've identified that and they're trying to do things. And I've seen the changes in the newborn ICU. It's just now getting it into that prenatal care also. The leading cause of death from unintentional injuries in children is what? Unintentional. That means it happened. It's not like child abuse, and that would be intentional. And I mentioned it briefly with the adolescents, but it's motor vehicle. Motor vehicles, and I'm talking putting them in car seats inappropriately. They should be infants, rear facing, and they're staying in the middle of the car, believe it or not. We have always on one side, I've noticed, but also getting run over by cars. I've seen a lot of preschoolers, believe it or not, their aunt, their uncle, their father, their mother, next door neighbor ran over them with the car. I've seen good outcomes and I've seen not so good outcomes, but motor vehicles is the highest of unintentional injuries. Which statement is most descriptive of pediatric family-centered care? So we know, especially the younger children and even some older ones, we know the one thing a child knows is their family and what the family, what they do, even on an everyday basis. So the family is the constant in their life. That's what they have every single day. The major cause of death for children older than 1 year is. What did I say about these 1-year-olds, these toddlers, ages 1 to 3? They're the dive bomb kids, right? There's no fear. They want to jump, they want to bounce, they want to go from here to there. And it is called unintentional injuries. Yes, it is. They just, are exploring the world and they do get hurt that way. We can't prevent all of it. The nurse caring for the child in pain understands that distraction distraction is something we use a lot in pediatrics. It's taking the focus away from what's happening around them and putting it somewhere else, which is more interesting. But remember, when we use distraction, it must be on the level of the child, developmentally appropriate. You wouldn't give a book to read to a toddler age 1 that didn't have pictures in it, right? So we need developmentally appropriate. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? And that's associative. Solitary is alone, by themselves. Parallel is next to each other, by themselves. Associative is they playing together, but there's no goal. There's nothing, there's no outcome. It's not like checkers, somebody wins, or the sandcastles build. That's cooperative. Which statement best describes the process of critical thinking? Isn't this something you were told the first day of orientation? You're going to learn how to critically think. And you're like, gee, what does that mean? I always say critical thinking is I look at my cabinet, see what I have, go to the grocery store, pick up the things that are missing for that dinner, come home and I make it. That critical thinking is knowing what I have and what I need in order to do what I have to get done, right? It's purposeful, it's goal directed. Very good. What is probably the single most important influence on growth at all stages of development? I think I said it 3 or 4 times today.
Oh, shit. Amen.
Nutrition, nutrition, nutrition. Growth. You're not going to grow properly if you don't feed the fuel to the car, to the brain. If you're not giving them nutrition, there's nothing to grow from. Okay? So nutrition, nutrition, nutrition. Without that, nothing else matters. Frequent developmental assessments are important for which reason? We look at kids and we want to see, are they rolling? Are they turning over from their abdomen to their back to abdomen? Are they creeping, crawling, walking? Are they grabbing things? I mean, how alert are they? All of these developmental assessments we do on every child all the time. And when we're doing it and we finding delays, we can institute early intervention, speech, physical, occupational therapy, and we can get them caught up. And you know what's really neat about children? Once you institute these therapies, they catch up really quick. Children are resilient. So getting them that, finding out they have a delay and do an early event intervention, these kids can come around and be perfect. Which function of play is a major component of play at all ages? I mean, what does play promote? It's that sensory motor activity. It's taking the rattle, having it, holding it, shaking it, hearing it, and then taking that and doing more and more and more with it. And that's the learning, cognitive awareness and learning. So it is sensory motor activity. 3 children playing a board game would be an example of what sort of play? That's your cooperative play. That's cooperative. Remember, associative, yeah, they're playing together, but there's no goal. Nobody wins. There's not a finished product. The head to tail direction of growth is referred to as what? Head to tail. And cephalic is head, right? Cephalocaudal, that means you start with lifting their head, right? To get the neck control. And it ends up on their feet and walking. So that's cephalocaudal. What is the single most important factor to consider when communicating with children? You know, children, they don't like strangers. They've been told not to like strangers, and that's who we are. So if you get there, start playing with them, getting on their level, on their developmental level, you'll get a lot more done, okay? Because you've got to build that sort of trust there. And that's only when you're on their level. You can't talk over them. You have to talk with them and make it fun. This is why I said I went to work. I played every day. What 2-year-old pain assessment tool should the nurse use? Remember I told you there's 3 that I want you to know. Numeric, FLAC, and FACES. Numeric, you have the number scale, so they have to know numbers. FACES, they need to know what face looks like the way they feel. And FLAC it's nonverbal. It means it's the younger children. And yes, it's up to age 3. The faces start preschooler, age 3. So yes, it is FLAC. Numeric, you know, I've seen younger kids use it, but the book says age 8. At 6 months, an infant's birth weight should do what? No, we're going to learn more about this next week, but I always throw this in here because it's a question that's been seen in many places. Or you need to understand this in order to apply it to a situation. So at 6 months, it doubles. At 1 year, triples. Can you imagine? Born at 7 pounds. At 6 months, they should be at 14. Now, if they only weigh 9 pounds, what's going on? They're not getting enough nutrition. And what's happening? They're probably cognitively delayed because you're not feeding the mind. They're not getting the nutrition that they need. They're probably not rolling over. They're probably not doing any of the things they should because they don't have nutrition. Now, conversely, if they weigh 19 pounds, I think they're overfed, right? And maybe we need to cut down that because an overweight child, you know, has other issues that we would talk about, okay? The first expected fine motor development milestone for an infant begins with. Now, there's two sort of motor things. There's fine, which is fingers. F for fingers, fine. And then there's gross motor, which is G, get up and go, 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 like Paw Patrol. That's movement. That's walking. That's crawling. So first thing they do is what we call a reflex palmar, which means mommy goes in and sees her brand new baby, puts her finger in the hand, and the baby holds it. And they go, oh, look, my baby's hugging me. Look at that. Well, it's a reflex. I'm not going to tell them that because they think that their baby's hugging them, right? That's fine with me. But later on now, they're going to grab that rattle, and that's a voluntary. Then it goes into the pincer grip, which is those thumb and forefinger. It starts out with sort of a mush, like maybe Cheerios on a high chair, right? Mush in the face. But then it gets to be one at a time. Then we take and we put objects into a container. And by 1 year old, they should be able to build a tower of 2 blocks. That is fine motor for the first year. That's one of those sequences you should know. An 8-month-old infant should be expected to perform which fine motor skills? After I told you that sequence, what do you think would be appropriate? So they should be able to grasp the rattle and then use the crude. Yes, they're not at that fine moment yet. So that's a very good one. Thank you. Good job. The natural physical developmental sequence that most children follow is what? And this is more of like gross motor physical development. That's the get up and go, 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 right? Well, if you look at all of these, what's the first thing that most children should be able to do? And they should be able to lift their head. That's number one. Then they go from the abdomen to the back. Then they go from back to abdomen. Then they're going to be able to go up on their knees, and they're going to crawl. And then they're going to, by 8 months, sit up alone. Then they're going to stand up, walk around the couch, cruise, and they should be starting to walk, the gestures towards that at 1 year old. Now, some kids are walking by 8 months, 7 months. That's quick, but not all children have to do it. And if your child isn't, it doesn't mean that they're behind. They're going on their own schedule. Which behavior indicates that an infant has developed object permanence? What does that object permanence mean? So once you show a child something, an infant, and they see it, like the rattle, and then you hide it, they know it's going to be there somewhere, and they're going to start looking for it. And that is searching for that hidden object. That is object permanence, okay? It's not recognizing things, none of that. It's knowing that even though they can't see it, they know it's here somewhere, and they go looking. In general, an infant should triple their birth weight at what months of age? So remember, they double their birth weight at 6 months and they triple it at 1 year. Good. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning the exam is what? I've said it a few times already. Always prepare and get on their level, get down on their level, not towering over them, and make sure when you're explaining that you are on their developmental age so that you're not scaring them is basically it. So, and they know what's happening. And as I always say, be honest. I'm going to do this and this. It's going to get tight. Let me hold your leg for you so you don't move. According to Piaget, toddlers are in the blank developmental stage. Well, trust versus mistrust is infants. Autonomy versus shame and doubt is toddlers. Formal operation, and those are Erickson. Formal operation is your adolescence. So it's sensorimotor. Okay, and we're going to go over this more next week also to give you more. I mean, those theorists, it's a lot to remember, and I'm going to give you those key things you have to know. Which intervention helps a hospitalized toddler feel a sense of control? I think toddlers in the hospital are probably one of the most difficult children to work with, because toddlers are those who do not like change. They don't want to be separated from mommy. And, they're very upset. And the biggest thing is go on their same routines. Is the food the same? If you can, try to give the same foods. Bedtime, same times. Nap time, same times. The types of foods, the baths at the same time. Try everything to be as close as possible. And that actually gives them comfort. And because they know what's coming next. Always those usual routines, making sure we follow them. And as nurses, we have to make sure that we build that into our care for that child so that we know at this time I can't bother him. He's going to take a nap, right? Those are things you got to know. All children reach developmental milestones at the same age. Yes or no? All kids walk by 12 months old. They're all different. Every kid is different. And the thing with this developmental milestones, as long as they're moving forward and they are progressing, your kid is okay. Not all kids are the same. And parents do that. They'll compare this child to this child and to let them know, no, you don't have to do that. They're all different. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for an infant? Well, how do infants soothe themselves? When my grandson was 1 month old, he went for a circumcision. He had really tight skin. They had to do it. And they did the whole procedure with a little bit of sugar water on a pacifier. It is like giving morphine to a child. There is a research article that was out by Harvard neurophysiologists, I believe was what they were. And they did a study, morphine versus sugar water or sucrose on the pacifier, and they found no difference. So how do they soothe? What do we do for infants? Number one, in mommy's arms, right? Number two, giving them that pacifier, and it helps decrease the pain. We use that a lot, starting IVs and drawing labs and doing urine catheterizations. Any of that, the pacifier, it does work and it calms the child down. Which of the following immunizations can be administered to a newborn? What's the first one we give? Does anybody know? You're going to see a whole list of a whole bunch of immunizations in your chapter.
I know they get the vitamin K.
Yes, they do. It's Hep B. The hepatitis B is usually given before they leave the hospital. Now, on occasions, I've seen it not given, and it usually has something to do with insurance. And then that 2-week visit is when the doctor will give it in their office. But usually they give that before they leave. And if a mother has hepatitis, they'll give it within, I believe, 12 hours of birth. They have to give it. It's they do it even quicker. The normal heart rate for an infant is why would you want to know what a heart rate is? Well, you're giving digoxin to an infant. When would you hold it, right? If it's below 100, you're not going to give it, or 120, whatever the physician writes, because normal is 140 to 160. How would you know that they're dehydrated? They're at sleep and their heart rate is 220. These are things why you need to know the difference in heart rates, okay? That's what you would be thinking about. What is the preferred site to give an injection to an infant? And sight is spelled wrong. It's not vision. And that's the vastus lateralis. And if you saw that picture of that nurse by herself giving an injection, I would never have you do that, because I've seen too many infants and children have scratched with needle marks because they didn't have appropriate holding. You know, that parent could be holding them and then another nurse hold the leg and you give it. Yes, safety is always important, especially with immunizations and injections. The death of an infant under 1 year old with no known cause is called what? And that is why we do not put them to sleep on their abdomens like this picture. You know, they used to say you could put them on their sides, but we have found out they're still inhaling their CO2 over again and over again. And it also causes, you know, SIDS death. So SIDS death, sudden infant death syndrome, is under 1. We don't know why it happens, but it does. But we do know the one thing that can help decrease the incidence is having them sleep on their backs. They feel that that works, and there's all sorts of research done. I know the hospital where I come from, they've been studying it for the last 20 years, and they've seen drastic decreases in SIDS death by this back to sleep. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why does she do that? I think you can see how culture and understanding it could help you understand the parents, right? Or even the children. And you know something? If you ask the mother, so why don't you look at me? She would prefer that than you wondering. That's just all respect from her. And parents, people in general, are more happy to tell you about themselves and when you ask the questions, and they respect you more because you cared enough to ask. It really does make a difference. You learn a lot too. A child from Mexico is hospitalized for a serious illness. The father says the child is being punished by God. Why is he saying that? This is absolutely a common belief. In fact, when we're going to go into the preschoolers, it's a belief that they believe they something wrong happens to them because they've done something bad. They didn't listen to mommy, or they hit their sister, or a school age child who didn't do good on a test. They feel that they got their appendix started hurting because they didn't do well. So this is not an uncommon belief at all on many levels. Which term refers to times in an individual life when he or she is more susceptible to positive or negative influences? Remember in the PowerPoint, there's all those terms. This is a part of that. And that's called the sensitive period, okay? That's just something you got to go back and you need to look at. What is characteristic of the pre-operational stage of cognitive development? Again, this is Piaget. This is, again, thinking, right? It's all about putting things together. Pre-operational is, I believe, ages 2 to 7. But again, we're going to go over this more next week. I like to throw these questions in there to spark some understanding as you go through and look. You know, thinking is logical. No, they don't understand what that means yet. They understand that I can take the top off a jar and put it back on because I've seen it. Concrete, I've seen it. I understand it. I've been shown it. Logical, they can't figure things out yet. Okay, at this stage. It's more of seeing it, knowing it, and I can now do it. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? What did I tell you about Kohlberg? And this is all about they're doing things good or bad because of the consequence. People do things good because they want to be praised. And sometimes that bad things, well, I got to do it because I'm going to do it because I have to do it. I want that. So, all right, I'll be punished. It's okay. So it's understanding those things is what kids start to go through. Let's see how we did today. Number 3 is a future NI nurse. Congratulations. Number 2. Thomas Davis, good job. And number 1, Hyde. Number 4, Cat and Lord of something or other. Anyway, that was the first week's lecture. I will get all of this stuff and I will have it on your announcement probably before we leave today. Before this evening. I'll do the attendance and I'll put that rate up for you. I will repost all the stuff from the announcements to make sure it's there. I'm going to send that just in a message. I think that's the best way to get it to you. Again, if you don't get it, let me know. Send me a message. I don't get offended. Please let me know what you don't get and I'll take care of it. I don't get upset or bothered by stuff like that. If you don't have the information, that bothers me. So just let me know. Anybody who needs anything, always feel free, send me a message, text me, and I will help you. Again, good communication. I can work really easy with you, all right? So just let me know what you need, and I'm here for you. So that's it for today, guys. We did good. Have a good night. And remember, next week will be quiz 2 on this week's information. You'll do all right. Don't worry.
Thank you.
You're
Quick question.
welcome.
Thank you.